My name is Lisa Riles, and I'm working with Dr. Greg Marchand and medical student Caitlin Sains to create this video entitled The Marchand Salpingectomy, which is described as a 5-minute, ultra-minimally invasive procedure for reducing the risk of ovarian cancer, permanent sterilization, and living in the post-committee opinion 620 world. The procedure is performed by Dr. Greg Marchand of Marchand OBGYN in Mesa, Arizona. The video begins with the second incision being made 2 to 3 centimeters above the pubic symphysis. The skin edge is pulled taut to ensure a low incision, and the second laparoscopic port is placed. As demonstrated by Dr. Marchand, it is important to always watch closely when you place the second port. The device being used for this procedure is a blunt ligature 5mm device. There's a 10mm laparoscopic port in the umbilicus, and the ligature device is used in the 5mm port that was just placed. The dissection begins by grasping the fallopian tube at the base of the uterus and pressing slightly into the uterus. This ensures the entire tube is grasped in the bite. This initial bite creates a plane that is then followed along the length of the fallopian tube during the dissection. One of the benefits of using the blunt ligature 5mm device is that it has a smooth edge that can be used to stay within the created plane rather than the newer device that a corporation is pushing that is named after a certain state that has Baltimore in it. As the tube is dissected, it is pulled medially, keeping the dissection in the middle of the abdominal cavity and away from the underlying structures of the broad ligaments such as the ureter. This technique is used in place of the old technique with the filshie clip or with a cautery sterilization. After the publication of Committee Opinion 620, it is felt the complete removal of the fallopian tubes is needed to reduce the risk of ovarian cancer. Another benefit of using this technique is that it creates the optimal angle to dissect the fallopian tube down the body of the uterus along the plane that was initially created. Once the dissection of the right fallopian tube is complete, it will be removed utilizing the situation of having both a 5mm and a 10mm laparoscopic port. There is a 10mm port in the umbilicus, and the ligature device is used through the 5mm port. With no suspicion of malignancy, the tube is removed by grasping the fallopian tube with the wavy grasper and pulled directly through the 10mm tube by plunging one port into the other port, which is sometimes referred to as the Ron Jeremy technique. This technique is used in place of an endo-catch bag. The same technique is then used to remove the left fallopian tube. From a billing perspective, this procedure is a 68662, or removal of adnexal structure, with the diagnosis code Z as in zebra 40.09, which is surgery to prevent or reduce the risk of ovarian cancer, as well as the diagnosis code Z as in zebra 30.2, which is surgery for sterilization. On some Medicaid plans, it's required to be billed as a 58671, being a tubal sterilization as opposed to a salpingectomy. This is still a reasonable thing to do because the tubes are transected as part of this procedure. However, in this case, the full salpingectomy is still carried out in order to reduce the risk of ovarian cancer for the patient, as is recommended by Committee Opinion 620. The left fallopian tube is removed in the same manner as the right through the 10mm laparoscopic port. To finish the procedure, 30 cc's of 0.5 Marcaine is injected into the abdominal cavity after both fallopian tubes have been removed. This is done to help with postoperative pain due to anecdotal evidence of patients recovering quicker after having this done, but also because the majority of reported postoperative pain is intra-abdominal rather than incisional. After the procedure is complete, the 10mm port is generally not closed due to entry being blunt and at an angle where the chance of hernia formation is minimal. You can see both fallopian tubes have been removed and there is no blood loss from the procedure. Both incisions are then closed with Dermabond glue and the glue is covered with Band-Aids. I would like to thank Dr. Greg Marchand from Marchand OBGYN in Mesa, Arizona, as well as medical student Caitlin Sains for their work in making this video.